Welcome to Talk Dizzy to Me, the show that brings you a comprehensive look into the complex field of dizziness. Now here are your hosts, vestibular physical therapist Dr. Abby Ross and Dr. Danielle Tolman.
Welcome back, everyone, to Talk Dizzy to Me. I'm Dr. Abby Ross. I'm a vestibular physical therapist and neuroclinical specialist, joined by Dr. Danielle Tolman, also a vestibular physical therapist. And today we have two special guests on the show. We actually had the pleasure of working with Dr. Bery, Dr. Anand Bery, I should say, on this year's Life Rebalance Live put on by the Vestibular Disorders Association. And we're also joined by his colleague, Dr. David Hale. Welcome both.
Thanks for having us.
Yeah, so excited to be here. Thank you.
Thank you for joining us. And today we're going to be talking about differential diagnosis. So a patient walks into your office, they're dizzy. What does that look like from a broad perspective, making sure something more sinister isn't at play, narrowing down what type of vestibular diagnosis it is, and then also zooming in on more specific diagnoses that maybe we don't see all too often. Can you both start by telling us a little bit about your background and what brought you into the vestibular world? Dr. Bery, we'll start with you.
Yeah, absolutely. So I first started getting interested in the visual and vestibular systems in my undergrad, actually. I took neuroscience at McGill University. Always knew I wanted to work with patients and be clinical. So when I got to medical school, as they tell you, keep an open mind. I tried to keep an open mind, but it was very clear that sort of neurology and particularly sort of the vestibular system and visual neuroscience was where I wanted to be, and had a couple of great mentors throughout medical school and basically have never looked back. So that's kind of my story.
And Dr. Hale, what about you?
Yeah, once I became a neurology resident, I kept getting exposed to patients with dizziness, and I was so curious about how to approach them, how to make accurate diagnoses, and I got connected with really great mentors within my residency program. And once I met how welcoming everybody was in the field of vestibular medicine, I was hooked and haven't looked back.
It is a very small population of providers that treat this, and Danny coined this term years ago at this point, but we call ourselves vestibuloholics, and you two definitely meet the criteria for that. And you two also did some work together, correct? Can one of you tell us the connection there?
Yeah, absolutely. We were super fortunate to do fellowship together. So there are very few fellowships in North America for designed for neurologists in vestibular medicine. And David and I both did that fellowship, and that's actually how we met. We were co-fellows for a year, but we're still in routine contact. Both vestibular patients, clinical. Yeah, we had a great time.
Now, as Abby alluded to in the beginning, dizziness is a very, very broad term. So when somebody walks into your office and says they're dizzy, where do you even start? And Dr. Hale, if you don't mind, we'll start with you.
Yeah, I think that I just always try and remind myself that when I'm taking an approach to dizziness, that dizziness is a term that we as providers all have like very specific definitions of dizziness, vertigo, postural symptoms. And I have this little dictionary in my head, but the patient isn't reading my mind and they may not have read the same books that I have. So I, of course, want my patients to describe their symptoms and let me know what they're experiencing. But as they're going through that, I'm starting to pick up clues and I'm listening to them and their open-ended description of, how things started, the timing of their symptoms. Are things acute? Are they episodic? Or have they been chronic? And then what's triggering their symptoms, especially if they are episodic? And I'm starting to categorize their symptoms based upon that. A lot of times, if you just let the patients talk and tell their story, those things will naturally come up. But of course, asking targeted questions and then adding on what symptoms are associated with that is, I think, like a really broad overview of my approach when the patient's in front of me in clinic.
I agree. It's about asking the right questions. And if you do ask the right questions, eventually they're going to give you the answers that you need, oftentimes from the history alone. When we think of timing, actually, let's back up. In terms of symptoms, what types of symptoms are you listening for that guide you in a specific direction for diagnosis? Or is it more about the timing of the symptoms for you, Dr. Berry?
Yeah, so I think, one of the first questions sort of in my mind as a quote unquote, vestibular provider, is trying to answer this question, are the symptoms vestibular in origin? And I'm sort of using the word vestibular in its broadest sense, right? Whether peripheral vestibular, central vestibular. And so, a lot of evidence over the last decade and a half, as Dr. Hale was alluding to, has really showed us that the symptom quality, the type, whether a patient's using the word dizziness or vertigo, doesn't have a ton of diagnostic value. But I think as Dr. Hill was saying, it's helpful. We really want to know what the patient's experience is. Symptoms that I do find helpful in terms of pointing towards a vestibular cause are symptoms like head motion intolerance. So patients really wanting to keep their head still, feeling more sick if they're moving their head. Nausea, I think often, but not always, obviously, but can point towards a more vestibular etiology. And if the patient is really telling you that there's illusory self motion, they're feeling like they're tilting, feeling like they're spinning, I think that has some value, but we don't want to over rely on it. And certainly patients with non-vestibular etiologies can describe that sensation as well. And then I think associated symptoms, right? If someone's telling you they're having palpitations or they're having chest pain or they're having shortness of breath, then we really want to pay attention to that and think, okay, maybe this isn't quote unquote vestibular in origin.
And it sounds like the timing of these symptoms may also give you a clue into that history. Could you expand on that a little bit?
Yeah, absolutely. So sort of first question for me is, is this vestibular? And then if we are thinking that possibly these symptoms are vestibular in etiology, then the next step is to sort of ask about timing of symptoms. And you can really sort of cut your differential into two really once you sort of focus on timing. So really the question that we're trying to answer with timing is, are the symptoms acute and continuous? And a way I like to ask that of patients is to ask them, if you're still sitting quietly, maybe with your eyes closed, are you still having active symptoms? And if the answer is yes, then I think we're dealing with more acute continuous symptoms, particularly if this is the first time, the first episode. Whereas if they're clearly telling me that, no, there are distinct episodes, then we're thinking about the episodic case.
And Dr. Hale, which types of diagnoses would you list under more acute versus episodic versus when we get into the more chronic, more persistent type symptoms?
hmm Great question. So I'll step back and first say that I think a lot of it depends on the setting that you're in. And a patient who's coming to my outpatient clinic or an outpatient vestibular therapy clinic could be a very different patient who's coming to urgent care or the emergency department with their dizziness. So setting does matter a lot. But when I think about my acute onset continuous dizziness, my big buckets are central localizing problems like an ischemic stroke versus a peripheral localizing problem that causes acute onset dizziness, like vestibular neuritis. And I say central localizing because it's important to remember that stroke is the problem that we do not want to miss with acute onset dizziness, especially in an urgent setting. But there are other central localizing problems like multiple sclerosis lesions, for example, that can cause acute onset dizziness that's continuous. So, but I think for the purpose of that, it's easy to put it in those two buckets. Episodic wise, it's important to remember that still episodic vestibular symptoms can bring you to an emergency department because someone has to have a first time episode of their dizziness and it can be very troubling. But there are also patients who have episodic symptoms for many months or even years that end up coming to clinics. When things are spontaneous, which is how we break down episodic to know if this is spontaneous, is it happening by itself? I think about Meniere's disease. I think of vestibular migraine, and the cannot miss diagnosis there, which often is coming to your emergency department, is a transient ischemic attack or a TIA. But if those episodes are provoked by something, especially a position change, of course think of BPPV, benign paroxysmal positional vertigo, which you are both experts in. But common things too, especially in the acute setting, like orthostatic hypotension, with someone feeling those vestibular symptoms from orthostasis with a change in body position. There are less common presentations, things like vestibular paroxysmia that can cause episodic symptoms as well. And that might be coming to your outpatient clinic. And then we move on to the chronic dizziness, which is diagnoses like persistent postural perceptual dizziness, Maladie-Debarkment syndrome. A lot of times these patients are being evaluated on an outpatient basis, but with worsening or flares of symptoms, might present acutely as well.
You bring up a good point where your clinical setting is really going to drive what type of history you're taking, what kind of tests you're running initially. Being in an urgent care is going to be very different than being in an outpatient clinic as a physical therapist. But there are times maybe you have a really great relationship with a physician in the area and they just send all their dizzy people to you, and you might be seeing them off the street. Even if you're a physical therapist, you need to know how to assess for those red flags and get them to the person that they need to see immediately. So I agree. It's really going to change of what kind of histories you're hearing, what kind of bedside evaluations you'll be performing based on your clinical setting. So your clinical decision, your flow of that. You've taken your history. What's the next step for a typical patient that you're seeing for dizziness? I know it's a very broad question. Dr. Berry, we'll start with you.
Sure. So I think as a first step, I really like to think about, are there any red flags? So if we're particularly in the acute case, are there features on the history outside of dizziness that make me concerned that there might be a sort of central cause here, as we talked about central localizing problems. So one of those features is acute hearing loss. So if the patient's telling you that they're having, hearing loss with their acute continuous vertigo, that is a red flag for me, because ischemia in the AICA territory can cause hearing loss. Other features, double vision. We have this mnemonic, the so-called deadly Ds, and basically these are other symptoms aside from dizziness and vertigo that localize to the posterior fossa. So these would include symptoms like diplopia or double vision, dysphagia or difficulty swallowing, dysarthria, difficulty speaking, anything else that's sort of a focal problem, sort of if they're sort of ataxic, focally on one side. And then another big feature is sort of, their gait. If someone is really having sort of a marked gait ataxia, imbalance, that's also a red flag for me in terms of, is this sort of more like a central process? So those are kind of the first level questions. And then I'm sure we'll get into what the examination is that we get to, but just on the history, those are kind of the red flags for me.
Yeah, you segued nicely for me here, because that's exactly where I was going to go. In terms of examination, what are you looking for, and what would give you an inclination that this might be something more sinister? So, for example, what types of nystagmus might make you think, or patterns of nystagmus might make you think this needs more urgent care? Or even the hint exam, where does that come into play? Dr. Hale, why don't we start with you?
Yeah, I think that one of the reasons why we try very hard to categorize patient symptoms based on timing and triggers and assign them as acute, episodic, or chronic, because it not only provides a differential, but it also guides us in what exam we're going to choose. Of course, I think Anand and I are biased as neurologists, so no matter what, we have a full neurologic exam in our background, but in terms of our vestibular exam that we're choosing, it is very heavily dependent upon, acute, episodic, or chronic. For patients who are presenting with the acute vestibular syndrome, the acute onset continuous dizziness, that's when we're employing the HINTS exam. And the HINTS exam is just a mnemonic or a battery of tests that we can utilize to help differentiate between a central localizing process and a peripheral localizing process. You specifically asked about nystagmus, which is the N in HINTS, but I guess I'll go through, what it stands for, and then I'll pass off to Anand to talk about what might be central or peripheral. But HINTS is the head impulse test, nystagmus evaluation, and then doing something called the test of skew.
So, when talking about how to interpret the hints, it's really useful, I think, to think about what's peripheral, what points peripherally, and then anything else that you're seeing, we're going to assume it's central until proven otherwise. That's kind of how hints was designed, to be as sensitive as possible to pick up a central cause. So we can start first with the HI, the head impulse test. And really what you're looking for on the head impulse test is you're basically looking for a refixation saccade. So when we perform the head impulse test, we're having the patient look at a target, for example, our nose, and we're moving the head quickly. So we want to move the head sort of 20 to 30 degrees, quite quickly, actually, at about 100 degrees per second or more. And usually what we tell novices to do is to start sort of eccentrically and move the head back towards center, just because it's much easier to get a sense for where center is. Very easy to go too far the first couple times you try it. And what you're doing is you're really watching the patient's eyes as you do this maneuver. And you really want to see whether the patient can keep their eyes on the target. If you see, the eyes slip off and then a refixation, the eyes having to find the target subsequently, that's what we would, term a peripherally sort of localizing hints or head impulse test, I should say. So we're actually looking for the sign in the head impulse test to tell us that something is peripheral. We're looking for that refixation. Then moving to the N, the nystagmus. So there's one pattern of nystagmus that's going to reassure us that this is a peripheral process, and that's a unidirectional nystagmus. So what we want to see is, the patient's looking straight ahead, and for example, they have a right beating nystagmus. There might be a little bit of torsion, a little bit of vertical, but you're going to see a right beating nystagmus. And then when that patient looks to their right, you're going to keep, the direction is going to remain right beating. So it's going to, remain right beating. It might get a little bit more as one looks in the direction of the so-called fast phase. But then when they look to the left, it should still be right beating. If they look up, it should still be right beating. So it's going to be the same direction. The direction of the fast phase is going to remain the same. So unidirectional nystagmus is the pattern that we're looking for in a peripheral process. And then the TS is the test of skew. And so with the test of skew, what we're basically looking for is a misalignment of the eyes. And so we ask the patient to look at a target, ideally across the room, and we alternately cover the eye. So we cover the right eye while they're looking at the target, and then we cross over to the left while they're sort of maintaining fixation. And we look to see when we uncover one eye, is that eye moving? And specifically what we're looking for in the context of the HINTS exam, of the test of skew, is there a vertical movement? So when I uncover the eye, does it, have any movement up or down? Is there any part of that trajectory that's sort of an up or down movement? Many of us, I would say even most of us, have some degree of horizontal misalignment, but it's really the vertical movement that we're looking for. And if we see that vertical movement, that points central. So we don't want to see a vertical movement. So again, to summarize what we're looking for, to be reassured that this acute continuous dizziness is peripheral, we're looking for a refixation saccade on the head impulse test. we're looking for a unidirectional nystagmus, and we're looking for no vertical movement on the test of skew on that alternate cover test.
And I'll just add to that. On the flip side, what if it is central? Well, I think it's important to remember that to feel reassured, like Dr. Berry said, there's an and in there. So you have to have all of those components. But if you're not satisfying all of those components with your hints exam, then you need to be concerned that there could be a central localizing process occurring, and that's when you start to evaluate as such. So just to reinforce that, it's there would be no catch-up saccade or no refixation saccade with the head impulse test. The nystagmus is not going to be unidirectional. It could be vertical. It could be purely torsional. It could be what we call direction changing, meaning that the patient looks to the left and the nystagmus is beating to the left, and the patient then looks to the right and the nystagmus is beating to the right. Or it could be mixed. There could be a combination of both upbeat and torsional, but it's happening spontaneously, not provoked by a maneuver that you performed. And then the last part of that, of course, is if there's a vertical refixation when you're doing your cover uncover test, that's termed the vertical skew and should be assumed to be central localizing in the setting of the acute vestibular syndrome. And there's ors in between all of those. So if you just have one of those, it means that you have to really search for that central cause.
That kind of goes into my next question, kind of going back to the nystagmus. I like that you mentioned that you really want to see a little bit of each of those tests, right, to kind of combine and give you a bigger picture. Um, in physical therapy and physical therapists that are treating vestibular dysfunction, a lot of them get really nervous when they have this patient come in. They have been chronically imbalanced. It seems like their imbalance is getting worse. They're going through bedside evaluation and they find downbeat nystagmus and they almost immediately panic. Could you talk about what what that might be, how you would start to explore that aspect of a patient presentation? We'll start with you, Dr. Hale.
Yeah, that's a great question. So downbeat nystagmus is something that we say localizes or is coming from broadly our cerebellum, and more specifically the vestibular cerebellum. So there are different nuclei within the cerebellum called our flocculus, paraflocculus, nodulus, and uvula. And when those areas are damaged for some reason, um, it can cause different patterns or can cause downbeat nystagmus, among other things. And we broadly say that this could be due to some sort of cerebellar degeneration or a cerebellar localizing ataxia. And it is something that's certainly worrisome and requires evaluation, but it's typically, especially if chronic, thankfully not an emergency, but it's something that we can evaluate on an outpatient basis. They should see and be connected with a neurologist who often specializes in movement disorders, or if someone like Dr. Berry or myself in vestibular neurology too, because we're going to be looking for a broad range of causes that can essentially cause degeneration of the cerebellum. That is in a non-specific way, it could be things like metabolic problems, like vitamin deficiencies. There are immune-mediated problems. There are also genetic causes of this, and if it is a rapid onset, cancer-related causes or what we call perineoplastic causes. So we can't tell the cause just by looking at the patient's eyes or their exam, but we have to rely more heavily upon all of the information that we're going to collect with lab work, imaging, more history from that patient to kind of put into those other buckets, essentially.
I remember back when I was first starting out as a vestibular physical therapist, and when you're learning, it's really drilled in your head. If you see vertical nystagmus, you need to be thinking, referral. You need to get this person to be seen by a neurologist or someone else. So it's really cool to hear from a neurologist standpoint what then you think about. And I think that will be really helpful to the vestibular therapists hearing this episode. So thank you for that. If we go back to the hints exam now and we see a pattern develop that we're suspecting something neurologic at play here, When we're thinking about something like a TIA or a stroke, what type of diagnostic imaging are you usually recommending for that? Dr. Berry, we'll give this one to you.
Yeah, absolutely. So I would say if you happen to be in the outpatient setting, okay, and you're seeing someone who within the last couple of days has had acute onset of dizziness or vertigo, and you're going through the pathway that we've just talked about in terms of asking, worrisome symptoms, then doing the hints exam. You've done the hints exam. Now you're sort of interpreting what the hints exam is showing you. If you can't confidently say that this is a peripheral process, a peripheral vestibulopathy, then I think this is a patient who you really want to be, sending to, an acute care setting, whether ideally the emergency department or urgent care. So I think it's a really good question that you're asking in terms of what is the next step going to be when this patient ends up in that setting. And so really the imaging test that is ideal and that will be obtained is an MRI of the brain, because that really is the imaging test that's most sensitive for a problem in the posterior fossa, sort of a lesion in the cerebellum, many of the parts of the brain that Dr. Hale was talking about, or the brainstem. So it's really an MRI of the brain that one would be looking to get. And sometimes, these lesions, though they cause a lot of havoc and cause a lot of symptoms, can be really small. And so really, from our perspective, the ideal type of imaging in this case is an MRI of the brain where you're really getting a detailed view of the posterior fossa. So, at an academic center, sometimes they'll even protocol the MRI a little bit differently to get sort of thin slices through the brainstem and the cerebellum. But really the key imaging study that you're looking for is an MRI scan of the brain. One thing I will say is that you're suspecting something central, you're getting the MRI to sort of confirm that. But if your examination, points towards a central cause, particularly if you're in that early window, that first 1 to 3 days, we're going to work the patient up as if they're having a central cause, regardless of what the MRI shows. And so that would include a stroke workup. And you've been asking about imaging, so I feel compelled to sort of put in that very likely we would also want some sort of vascular imaging to look for lesions in the vasculature, both in the neck and in the head, as a cause potentially for a stroke. So that would include something like a CT angiogram or an MR angiogram. But the textbook answer is it's the MRI brain that we're looking for to rule out a stroke.
And sometimes you use that imaging to rule out other central causes. And if you do have something that comes back negative, where's your next step from there? I know a very common diagnosis that comes back with a clean MRI would be migraine, central related, but not necessarily, showing signs of stroke. Um, so could we kind of shift gears a little bit and kind of get into a migraine discussion and maybe talk about the pathophysiology behind migraine? And we'll toss this over to you, Dr. Hale.
Yeah, in terms of migraine, I think that I am when I'm in the episodic vestibular syndrome, I'm using diagnostically a lot of my associated symptoms. I always rely heavily on my diagnostic criteria for vestibular migraine, and Dr. Berry and myself both follow the Barani Society or the International Society of Neuro-Otology's diagnostic criteria, along with the International Headache Society's joint criteria of vestibular migraine, which is at least 5 episodes of vestibular symptoms, with 50% of those episodes being associated with migraine symptoms. So either the light sensitivity and sound sensitivity, the migraine headache itself, a visual aura, half of the time. They have to have a current or prior diagnosis of migraine, which might be a remote migraine diagnosis. And the most important part is that it can't be explained by another vestibular diagnosis, or I can't have an alternate cause for their symptoms. That doesn't mean that there can't be two things going on, which is often the case, but I have to then rely on my exam to exclude alternative causes, and that's kind of the approach I'm taking when I'm evaluating a patient with migraine. In terms of migraine pathophysiology, I don't think that one person could say, like, oh, this is exactly what's going on with migraine. This is exactly the pathophysiology of it. But there are a lot of different theories or hypotheses about what could be causing vestibular migraine. And I think one thing that we like to remind ourselves is that the CGRP system, which is present and included in migraine, those receptors are found throughout our entire vestibular system as well. So if they're being activated within our brain, causing other migrainous type of symptoms, it makes sense that they can be activated or stimulated within our vestibular system as well, leading to vestibular symptoms that can occur with migrainous symptoms. In terms of migraine, you can find central localizing features either while they are acutely symptomatic during a attack of vertigo or dizziness, but also in between that are more mild. Uh, a review that was done by Dr. Caradmond, who's one of our colleagues, found that the most common thing that's described in patients with migraine is saccadic pursuit or choppy, smooth pursuit, which is often nonspecific. But otherwise, patients can have positionally induced patterns of nystagmus in between their episodes. That's often a very low or slow velocity that isn't exactly fitting a peripheral cause otherwise, which could fall into a larger category of like a central positional nystagmus, and you'd be evaluating in that lens. But there was a really interesting study, and I don't know the names of the authors, unfortunately, but I know it was done in Australia, where they sent patients with vestibular migraine home with a VOG goggles or video oculography goggles, and they had them record their eyes spontaneously and in different positions when they were symptomatic from their migraines, and they found a whole host of nystagmus, spontaneous horizontal nystagmus. They found some spontaneous vertical nystagmus less commonly, but also positionally induced nystagmus that was very apparent during their attacks or symptomatic periods. So it can be really tricky, especially if that patient is the person in front of you in the emergency department and it's their first vestibular migraine, because you have to have a first one, and it could be troubling enough to cause you to present acutely. So that's why, we say central includes stroke. It includes the scary causes that we don't want to miss, of course. But migraine might mimic some of these things in the acute setting, and we always keep it in the back of our minds. But we say, well, it's suspicious for a migraine at this point, but I can't make that diagnosis just yet. With only one episode, we'll continue to follow you as an outpatient and go from there. I know this is a long-winded answer, but the last part I'll say is, if we see these central localizing problems on these patients, I think we're starting to exclude other causes as well. Like thinking back to like the cerebellar localizing problems and that cerebellar degeneration type of evaluation with like blood work, just to make sure we're not overlooking anything if we're seeing like clear signs otherwise.
And then to further complicate things, some of our patients with migraine also present with intermittent BPPV, and their nystagmus can change from session to session. So it really is sometimes trial and error. If they're not responding, if it looks like BPPV, acts like BPPV, but it's not responding to what we would typically expect, like an Epley maneuver, then we think, okay, maybe this nystagmus is presenting due to migraine. And just as an aside to our audience, we do have a couple episodes on atypical BPPV that can be helpful in this patient population. Now, let's say we are suspecting migraine. Dr. Bery, can you talk to us about what's your intervention plan looking like for that type of patient?
Yeah, great question. Something that I know Dr. Hale and I sort of have rehearsed, over and over and over throughout most of our clinics. But, I think I always like to start by sort of conveying the diagnosis, normalizing the diagnosis, talking about just how common, migraine really is. And I do like to tell patients that I think migraine is a state. It's probably a state that any of us could get ourselves into if we push ourselves far enough. And so really it's a threshold question, right? Some people have a lower threshold to get migraine. Some people have a really high threshold to get migraine. And so I really like to explain it in that way. And particularly in our clinics, I really like to emphasize how, you know, migraine can absolutely cause vestibular symptoms in isolation. Even if there's not a headache at the same time, recognize completely the diagnostic criteria, and to be confident in the diagnosis. Really, we would like to see either a history of migraine or strong migraine features during the attack. But have I seen isolated episodic vertigo, maybe with a history of motion sickness, and that's it, and we treat as migraine and it improves? Absolutely, over and over again. That's a situation. So I think just conveying the diagnosis, getting the patient to understand that you're not talking about classic migraine headaches, because if they haven't bought in to what you're telling them, I think the treatment part is going to be really difficult. And then I really like to think both in terms of conservative treatment lifestyle, which I think in many patients can make a really big difference, and then to think about medical, even interventional. So as far as lifestyle things go, we talk a lot about sort of keeping a diary. In patients who are maybe a little bit resistant to the idea of keeping a detailed diary 24/7, I really start by telling them, if you have a bad day or a bad episode, what was different 6 to 12 hours before? Are there any triggers that you can identify there? So starting with that, big things that I talk about on the lifestyle thing. I mean, one can go really down a rabbit hole of trigger avoidance, but big things that I focus on, obviously the big triggers: red wine, dark chocolate, MSG. And then really morning protein is a big thing. I find, a lot of patients aren't eating things in the morning, and I think their sort of blood sugar is dropping kind of midday, and that's a big trigger. Being regular about hydration. And then I think sleep, it really is huge, crucial, really, sleep, in addition to any specific triggers that they've already identified. And then sort of thinking, about, medical, I think about the different classes of medication. So I explained to patients that for many, many years, our treatments for migraine were borrowed from other classes of medication, whether that's a beta blocker, that are primarily medications, or initially were medications to slow heart rate, whether it's medications initially designed for epilepsy, like topiramate, just as one example, or gabapentin. Different classes of sort of serotonin acting medications, tricyclics, SNRIs. Those meds, given their broad spectrum, tend to be good migraine preventives. So many options, but sort of going down the list, thinking about compelling indications. Are there other symptoms? If the patient is having difficulty sleeping, something like a tricyclic might be something to go towards. And then, I talk a little bit about the specific, molecular targets that we now know, and that we have medications finally that are more specific for migraine. Dr. Hale alluded to the CGRP system. So we now have medications that act directly on that system. So just thinking in terms of, conservative, medical, and then there are interventions as well, whether it's, botulinum toxin or otherwise.
I like that you brought up patient education initially, because having that buy-in is so important. I can't tell you how many patients come in, we talk about migraine, they always say, but I've never had a headache. I've never had a headache. I've never had a migraine. I've said that doesn't necessarily mean X, Y, and Z. So it's really, really good to hear. I do want to shift into one more topic before we wrap up. I can't believe we're already, blowing through this hour like it's nothing. We could talk to you guys all day. But I want to talk about vestibular paroxysmia. So, Dr. Hale, could you just at least start to describe what that is for us? What is vestibular paroxysmia?
Yeah, vestibular paroxysmia is another vestibular diagnosis that again does have specific diagnostic criteria through the International Society of Neuro-Otology, but it's clinically described as brief, repetitive, stereotyped, meaning typically the same episodes of vestibular symptoms and can be associated with hearing symptoms that are occurring on a daily basis for some patients, and it can come in clusters. So the story that we might hear is that a patient is having sometimes upwards of hundreds of episodes a day of brief second long feelings of dizziness or vertigo or a shift that can be preceded by like a electronic or like a radio type of sound in the ear, but not always. um, Part of the diagnostic criteria of this is that there can be a response to certain medicines like oxcarbazepine or carbamazepine, which are anti-seizure medicines. And from the neurologist point of view, it's something that we think of that can be like similar or akin to like trigeminal neuralgia, where trigeminal neuralgia is some sort of irritation of the nerve that provides sensation to the face. And we might think of this as some sort of irritation to the vestibular or eighth cranial nerve.
Now, how often does this type of diagnosis present in your experience? And also, is it also a diagnosis that's one not better explained by something else before you make it, Dr. Berry?
I would say yes. I would say that, among the different vestibular diagnoses that we've talked about so far, BPPV, migraine, even vestibular neuritis, I would say that this is a much rarer diagnosis, probably to some degree under-recognized, because again, we're talking about a patient who has very, very short episodes, not something that you're going to necessarily pick up on your routine vestibular testing, not necessarily something that you're going to see happen in front of you on the exam, not necessarily something that the patient is going to be able to capture at home. And so, I think, yes, it's rare, but probably a little bit under-recognized as well. One thing I will say is that vestibular paroxysmia can be truly idiopathic. So you do an MRI, even with thin cuts, sort of through the seventh and eighth nerve complexes, and you won't see anything. But the history is in keeping. You start low dose oxcarbazepine, the patient's doing better. You're kind of confident in your diagnosis. But in some cases, you will see what we call neurovascular contact. So what you'll see is that there's a loop of vessel that basically is in contact with the seventh and eighth cranial nerve complexes. And so you can actually see that there's the vessel touching that cranial nerve. And so it's kind of a difficult clinical situation because a lot of patients will, on imaging, have that finding. They'll happen to have a loop of vessel. It's not abnormal. It's seen in a certain percentage of the population, and they'll have no symptoms whatsoever. And in some patients, they'll be telling you, I have these episodes that are short-lived, repetitive, stereotyped. There are oral symptoms on the left side, and then you look, and sure enough, they have a loop of one of the vessels, a loop of AICA, for example, going right into that internal auditory canal. And that's where you have the slam dunk. Okay, you've got the symptoms, you've got the corresponding imaging findings, response to oxcarbazepine. So those are the satisfying ones. I think the situation that's sometimes less satisfying is when you have a patient with recurrent short-lived vestibular symptoms, but you're really not sure. Is it a bit of orthostasis? It might happen a little bit more when they're standing up, or, those are the situations that are a little bit harder. That there might be an older patient where you're not rushing to start them on a medication like carbamazepine. Those are the ones that are a little bit more difficult.
So is that diagnosis something that is treated with medication alone? Is there anything else that goes in concert with that, or will medication clear their symptoms up? Dr. Hale.
So Part of the diagnostic criteria specifically says that they have like quite a robust response to these medicines. And the times where I have had that satisfying story, like Dr. Berry just described, like they do have like great resolution of symptoms with medicine alone. But there are certainly times when that is not the case. And I can just share, of course, a de-identified example of a patient who had very brief episodes of repetitive vestibular symptoms. I tried the oxcarbazepine, I got an MRI, nothing was really fitting fully. And I was like, well, let's just continue to follow your symptoms. We'll see what happens over time. And, within the same year, that patient began to develop more longer, prolonged episodes with migrainous symptoms. And I ended up treating as a vestibular migraine. And when the symptoms became longer, and visual sensitivities developed, I sent them to vestibular physical therapy. And I retrospectively looking back, I didn't have clues to think that it was vestibular migraine initially, but it kind of presented itself over time. So I think, even when things aren't perfect, just like keeping a high index of suspicion and continuing to follow your patient, and see how things will go, and ruling out any alternative causes, that are scary on imaging, of course, is important along the way. But sometimes like time will tell, and I just have a frank discussion with our patient of like, this is what we were suspicious for. Things aren't fitting perfectly. We're just going to keep a close eye on you and see what happens. Um, so that's how I think that, alternative treatments could come into play other than medicines for those patients who you're not 100% sure of course.
Thank you. Now, lastly, before we wrap up, as vestibular physical therapists, I'm curious as to with what specific diagnoses are you automatically like, yep, referral to vestibular therapy versus with which ones are you maybe reluctant or want to see how they respond to other therapies or interventions first? Dr. Berry?
Yeah, great question. So to maybe use some of the diagnoses that we've kind of been talking about so far, starting with BPPV, I think that's the classic. Definitely the patients with BPPV, you guys are the experts, and so that's almost always going to be a referral to vestibular physical therapy. I'll typically do a maneuver in the office and then refer on. But I really do think many or most of our patients can benefit from, vestibular physical therapy, whether it's migraine for habituation, whether it's, we were talking about downbeat nystagmus, sort of suggesting cerebellar dysfunction. I think we're absolutely on our side going to work up the underlying cause. But in terms of working on balance, working on tolerance to head movements, I think those patients really can benefit. If it's a diagnosis like vestibular paroxysmia, where as part of the diagnostic criteria, really there should be robust response to a low dose of a medication. In those cases, typically I'm going to try to treat medically first, both as a diagnostic and as a therapeutic test, and often patients will get better. But really, it's more the majority of our patients that I think could benefit from physical therapy, from vestibular therapy.
That's really good to hear. So our jobs are safe for now. Now, you had alluded to before we started recording that you guys have a couple of podcasts that you're on recently. Can you share those, and we'll share them in the show notes for people to be able to listen?
Absolutely. So that's the Neurology Exam Prep podcast. And we have 2 episodes. One is on acute vestibulopathy, and the other one is on episodic vestibulopathy. And really what we did with those is we tried to keep it as accessible as possible, starting right at the top. How do we think about a patient with acute vestibular symptoms, working through sort of evidence-based pathways, and same thing for episodic conditions. And so we'll make sure that we give you those links so you can put them in the show notes for everyone.
Perfect. Thank you both so much for coming on the show, and thank you to our audience for tuning in.
This podcast is provided for informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition.
The content of this podcast is based on general knowledge and information available up until the recording of this specific episode. Medical knowledge and practices may evolve over time, and new information may emerge that could change the understanding or treatment of vestibular dysfunction. It is important to consult a qualified healthcare professional for the most up-to-date and personalized advice.
The information provided in this podcast is meant to complement, not replace, the relationship that exists between a patient and their healthcare provider. It is intended to empower patients with knowledge about vestibular dysfunction and its management, but individual cases may vary, and treatment approaches should be tailored to each patient's unique circumstances.
By listening to this podcast, you acknowledge and agree to the terms of this medical disclaimer. The organizers, presenters, and creators of this podcast are not liable for any actions or decisions taken by individuals based on the information presented herein. Always consult with a qualified healthcare provider for medical advice and treatment.